Assalamualaikum warahmatullahi wabarakatuh. Good morning to all, professor, doctor, colleague, resident, and student. My name is Rahadian. I will be your moderator today, and we would like to welcome our visiting professor, Professor Alexander Nistor, MD, PhD, who will be presenting to us a very special topic today: the future of microsurgery, which is robotic lymphatic surgery. Before the lecture, I would like to please welcome for the opening speech by the Program Director of Plastic Surgery Residency Study Program, Dr. Prasetya Nugraheni Krasanti, Plastic and Reconstructive Aesthetic Surgeon, Craniomaxillofacial Subspecialist Consultant, to give an opening speech. Thank you, Dr. Reni.
Thank you, Dr. Rian. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Thank you very much for your attendance to this very important lecture from our visiting professor. And we would like to extend our welcome to Professor Alexandru Nistor from Brussels University Hospital, Belgium. It is an honor for us, for our residency program, to have you, and hopefully, and I'm pretty sure that you will broaden our residents' horizon in this new topic, emerging topic. Hopefully, in the future, we can collaborate more in research and maybe in education. And maybe in the future, we can have the robotic surgery here in our hospital. And then we can do joint surgery with you as our mentor. So, without further ado, I think it is. I thank you, and we thank you very much for coming to our residency program and to give this lecture. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Prasetya Nugraheni, for kind opening speech. So we will next welcome our very own Head of Plastic Surgery Divisions, Dr. Aditya Wardana, Plastic Reconstructive and Aesthetic Surgeon, Burn and Wound Consultant, to give an opening speech. Please, Dr. Adit, thank you.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, Prof. Alexander Nistor. I would like to honor and thank you for your presence here as a guest speaker today, putting in extra effort flying from Belgium to Jakarta. Sharing your great experience in lymphatic surgery and robotic lymphatic surgery will be useful knowledge for us. I hope that we can expand our knowledge as a plastic surgeon and doctor after Prof. Alexandru's sharing session. And our dean would like to meet Prof. Alexandru and also our staff in around 9:30 to 10 a.m. this morning at his office. Thank you very much for your presence, Prof. Alexandru. Looking for your interesting lecture. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Aditya Wardana, for kind opening speech. And I would like to welcome a representative from the head of surgery department, which will be presented by Dr. Wifanto Sadityajo, general surgeon, digestive surgeon, subspecialist consultant. All the time and place is yours, doctor. Please.
Thank you, Dr. Radian, for your introduction, and good morning, college, ladies and gentlemen, fellow and residents. I'm Wifanto from Research and Education Coordinator, Department of Surgery from this university. And today I represent Dr. Diani, the Chief of Department of Surgery, to give opening speech in this fruitful lecture. It is great pleasure and excitement to welcome Professor Alexander Nistor from Brussels University Hospital and with us, and we are honored to give such distinguished lecture expert in the field of robotic lymphatic surgery. And here uh, he will share the well of his knowledge and the insight with us. Professor Nistor works uh, in realms of robotic lymphatic surgery, uh, has significant advance our understanding and capability in this critical area of medical research. His groundbreaking and contribution have paved the way for innovative techniques that hold the potential to emphasize the field of surgery, particularly in the treatment of lymphatic disorder. As we gather today, we find ourselves in the forefront of medical innovation, ready to delve and interactions of this cutting-edge technology, especially in robotic surgery. And with Professor Nistor expertise, we are privileged and explore the more advancement, challenge, and possibility that lymphatic surgery offers to the medical community. I encourage you to actively involve in this lecture today and ask questions and take full advantage of this unique opportunity to learn from a true expert in the field of plastic and reconstruction surgery. I congratulation to the plastic and reconstructive division to have this uh, lecture today. And once again, it is immense pleasure to welcome Professor Nistor to our institution and this lecture. Let us embrace this opportunity to expand our horizon and deepen our understanding of robotic lymphatic surgery. Without further time, I now open the lecture today from Professor Nistor and hope this lecture will enlighten us with his expertise from this field of surgery. Thank you and enjoy the lecture.
All right. So I would like to read the CV for our distinguished guest, Professor Alexandro Nistor. Can you please put the presentation on? So our distinguished guest, Alex, Professor Alexandro Nistor, MD, PhD. He is this is good, right? Okay. Next. Okay. So Dr. Nistor graduated from Victor Babes University of Medicine and Pharmacy in Timisoara, Romania. He also finished his PhD there and then a residency there as well. And then he recently got the Fulbright visiting scholar by visiting Memorial Sloan Kettering and Beth Israel Deaconess Medical Center in USA. Next slide, please. Right now, Professor Alessandro Nisor is a professor in Department of Plastic Surgery, Brussels University Hospital. And from 2007 until 2022, he is a university clinical lecturer and graduate teaching assistant in the Department of Microsurgery and Methodology of Scientific Research in Victor Babes University of Medicine and Pharmacy, Timisoara. and he's been a plastic reconstructive surgeon since 2016. Can you back to previous slide? All right. So he's been experienced in a lot of training in hand surgery, orthopedic surgery, and reconstructive surgery, also plastic and reconstructive surgery. Next slide, please. He is also right now the coordinator of Lymphatic Clinic in Brazil University Hospital. All right. And Professor Nistar has been involved in many research projects related to plastic and reconstructive surgery, including the medical infrastructure. Can you go back first? And uh, his recent contribution to microsurgery, including the study of swine model for perforator flap training in the living model. This is a very nice breakthrough and contribution for those who want to learn uh, about perforator flap surgery. And he's been doing this perforator flap course and flap surgery in his center in Piansbro, Romania, for almost 10 years and more, I think 20 years. Back, please. Yeah, he also published 21 scientific articles in international and national medical journals, 82 citation in Scopus and H index of 6. And he has presented his research in 74 Congress medical events in microsurgery and plastic surgery around the world. And he has written 2 book chapters. Okay, next slide, please. These are some the landmark article in microsurgery. What I'm presenting here is his recent publication in swine perforator flap model for training of residents and fellows. Next. He has invited to many events in the world, especially in microsurgery. Next. He also is one of the reconstructive microsurgery European School faculty, teaching mostly about microsurgery. Next slide. And he is involved in many organizations, including organizing the international practical course with total of 140 and 52 total participants in Piansbro Microsurgery Center in Romania. He has already taken care of 47 edition of microsurgery of facial nerve course, 24/7 edition of flap harvesting in living tissue course, and many more in perforator flap dissection course. He has also presented many awards during his career. Next slide. This is the picture of the Piansbro Center, which is his previously working, the website. This is the one of the earliest center for microsurgery training and flap dissection course in Romania. Already got like almost 2,000 participants from all around the world, and he's one of the faculty there. And he is also great mentor and colleagues. This is my picture with Alex during our time with Prof. Hamdi also in Brussels. Next slide. Yeah, roommate. And recently, like 2 months ago, I texted him about this Instagram post from UZ Brussels, which he's doing the robotic super microsurgery using the new Simani robots. And I was like, can you come to us and present to us so we know about it? And he was like, sure, why not? And then now we're going to hear from the expert himself about the future of super microsurgery or robotic lymphatic surgery. I hereby present you our visiting professor, Dr. Alexander Nistor. All the time is yours.
Right. So in the meantime, I would like to thank you for the warm invitation and to everybody who took time from their busy day to get here today, and especially to all the esteemed faculty guests, which I'm happy to meet for the first time, and hopefully we're able to share a little bit of knowledge. As all my speakers said before me, I think this is a unique opportunity for both me personally, because I have never been to this part of the world. And I think it's really interesting to see how medicine is being done in other places, in other conditions, and with other approaches. And I think it's very interesting from a point of view of whoever gets in contact with people coming from abroad. This is how I started initially to be interested with microsurgery. And this was quite a long time ago, but we'll get to talk a little bit about that. So thank you so much again for the invitation. And I do hope that the story that I'm about to tell you today, you will find at least interesting, if not something that you would like to personally continue and pursue. So, as my dear friend Ryan told already, I'm now coming from Brussels, which is quite interesting, nice city where the weather is not as good as you have it in here. So it's a nice change for the moment, and which is home to, you know, probably the largest number of beers in the world, and also for the Belgian fries. It's a capital mistake to call them French fries. You get a death sentence for that in there. This is the university hospital that we're currently working in. It's called the University Hospital Brussels, and it's part of the Free University of Brussels. I'm originally coming from Timișoara, from Romania. I think this is easier. So I'm coming from Timișoara, from Romania, and this is just now this year the European capital of culture, and this is a really nice time to be there with a lot of events happening every day. This is the University of Medicine that I originally graduated, and where I spent quite a lot of time in terms of microsurgery. And I started as a second year medical student just because the building was across the street from us. And I was watching from the anatomy lab all the time what's going on in that building. And I was like, I should go in and see what's happening in there. And what was happening in there, they were doing, courses, training courses, which are basically the only and the best way to learn how to do microsurgery, how to do a microsurgical technique. And this you can do mostly on small rodents like rats and mice. And this is what microsurgery is now known for. This is the definition, basically. This is what we call microsurgery. The boundary for microsurgery right now is considered around 0.8 millimeter. And that's a very funny number. That's usually the standard diameter of a femoral artery in rats. So anything beyond or anything below that is considered more than microsurgery. And we started calling it supra microsurgery. And then finally we settled on the super microsurgery because it just sounds better when it's super, no? And this is considered anything below kind of 0.7 millimeters. And there's no limit to how low it can get. And in Timișoara for a lot of time, I've been involved in a training and research center, which basically was all year round training, and from time to time all year round research, and from time to time we had some training courses. And this training program of ours started in 1998, so quite a lot of time ago, more than 25 years ago. And in the meantime, I think we had over 2,000 people visiting us from all over the world. And as you can see, this is basically a center where we try and share a little bit of our knowledge with some of the people which are interested in becoming mostly reconstructive surgeons. And I didn't say the word plastic surgeons because this is not specifically dedicated to plastic surgery. There's ENT, there's ophthalmology, there's neurosurgery, there's a lot of the surgical fields find nowadays an application for microsurgery, for the technique of microsurgery. And this is what it looks like in a big animal theater. And this is practically a fully suited operating room where we can have things like this, where we simulate on living organisms, living intubated pigs. We simulate what we do day by day in plastic surgery, which is free flaps. You can do many other things, but those are not organized by us, but other colleagues. So this is what it looks like when it's actually a free flap transplant. And the things can get really interesting because we have a lot of options, what we can do in there. And the latest addition to all of this has been, sorry, my image is gone. The latest addition to this has been a supra-microsurgery course, which we organized with colleagues coming from all over the world, from Japan, from Italy. And this has been a really, really nice opportunity for a very select number of colleagues, because we can only accommodate so many of them in there. And over the years, we had the pleasure of welcoming to our lab some of the, I would say, big names of plastic surgery, and we were happy to do that. I took it personally as an opportunity to visit back even more than the people that visited us, and try to extend and reach out to colleagues which are very well known for their craft. And this is where I basically started in the journey of lymphedema. I was just graduating from my residency training, and I started visiting some of the most important, let's say, reconstructive surgeons in lymphedema. And this continued with a very nice gallery of friends from all over the world. And I'm happy to say that hopefully I can add this nice picture of Jakarta Medical University to this growing list of pictures. And I think that in every place that you go, you should be really trying to get something from there back with you, besides really big and cumbersome paintings, which are now a burden to fly back with. But you should try to get back some knowledge. And the basic knowledge that we have today is rooted in what other colleagues of ours have been working on in the past, in the quite distant past. Everything that we have and we take for granted in our daily medical life has been in development, I would dare to say, for more than 20 years. And basically this has to do a lot of with this guy, which dared to say that, based on the scaling of computer chips, we can double the performance of everything technology related every 2 years. So I would dare to say that right now, for microsurgery, we live in an era which has never been as good as it is now, and for reconstructive surgery in general. And let me explain to you why. So some of you are medical students, right? What's the best solution when you have this problem? When you have cholecystitis, what do you do? not all at once. You take it out. Okay, cholecystectomy, so a removal. How do you remove it? Louder. Surgically, yes. I think it's difficult to do it otherwise, but how exactly? There's two options. Which one do you prefer? I think 99% of you will say laparoscopy. But it might surprise you that as little as 20 years ago, the answer was completely the opposite. And as little as 20 years ago, general surgeons, when they heard of this abomination called laparoscopy, they were literally rioting, as how dare you not open the patient from the xiphoid to the pubis and take all the guts out and expose them nicely on the table, as they learned to do it from their teachers and their teachers before, and so on and so forth. The image that you see in here, this is basically the standard since very little time ago, around probably the 90s. Before this, laparoscopy as we know it, it didn't exist. And basically, I'm missing a slide in here. Yeah. And basically it's the merit of this guy, which is more or less considered one of the fathers of laparoscopy. And he's coming from a gynecology department in Germany, in Kiel. And in 1980s, he performed the first documented laparoscopic appendectomy. But the actual time that this whole laparoscopy revolution started was almost 40 years before that, 20, 30, 40 years before that, with every single incremental step that was added to the puzzle, we advanced a little bit more towards this pivoting point. So the same happened actually with robotic surgery. And this is the parallel that I'm trying to make. Robotic surgery now in plastic surgery just now starts to become accepted. But it existed way before this, but it was too exotic to be even considered. And it still is considered quite, let's say, almost like a small gimmick, which you do just for the PR and the fun of it. But as you will see, and as I will try to convince you, hopefully this is not the case. So for those of you which are not very familiar with the topic of lymphedema, let me just quickly run you through this. Lymphedema is basically when those pipes in our body and those sewage drains, which are the lymph nodes, when they break down for a reason or another. So it's actually a transport failure in our body, a failure to transport some of this interstitial fluid that we circle around the body, and we call it lymph. So what's lymph? It's this, exactly as I said, fluid which we all soak in, and this has multiple roles, but one of the biggest, as we know it, is in the immune system. So this is carried through lymphatic vessels, and they are super small, less than a millimeter in diameter. The lymph is colorless, but in this image, you see it marked blue because we injected some contrast agent, and they're quite fragile. So this means that the reason we as plastic surgeons have started to do this is just because it's a structure which is really, really small, and probably there weren't many other surgical fields which were able to do this kind of vessel size. Even neurosurgeons, they don't deal with 1 millimeter arteries or vein. They just coagulate them and that's it. Even if this leads to a small stroke in that area. So this is what it looks like. Unfortunately, not every swelling in our body, or fortunately, not our swelling in our body is lymphedema. Sometimes it can be also by other causes. And I'm not going to go into that because you all know about renal failure and heart failure and how it turns into edema. But one very particular cause for upper limb edema is breast cancer, and specifically the axillary lymph node dissection that women get after breast cancer. And this is what it looks like. And if you look at the left arm of this patient, you can see the volume, the huge volume. And this is due entirely to lymphedema, the disproportion. So what does it look like? It's characterized by this distal swelling, and the patients are infection prone. And most important, this is a stigma. This is almost a handicap for the majority of them. They're afraid to go out. They're afraid to be seen in public with this. They become trapped in their own disease. But there's a big difference between lymphedema and something which sounds very familiar, but is completely different, and which is lipoedema or lipedema, and which is basically just a variant of adiposity with some particular distribution. So lipedema, unfortunately, we cannot treat in the same way that we treat lymphedema. And the best way how you can figure out these two is by just pushing a lot against the swelling. And if you see a pitting edema, then you have fluid retention. When you have non-pitting edema, then it's just fat, most likely. So what do you do? How do you treat these things? Well, for the majority of history of medicine, wrapping and bandaging has been the only solution to these patients, and to the point that this has become a part of their lives. And this means they are a burden to the medical system, first of all, because this is manual drainage, manual bandage. This is all cost intensive from the specialized therapists. And also from the patient's point of view, it's a burden to go 3 times, 4 times a week to get lymphatic drainage and to get bandaged and whatnot. But fortunately, plastic surgery comes to the rescue. And now we can offer some new things. And one of the new things is we can directly operate on the lymphatic system. We can either reconnect, like the cardiac surgeons are doing with bypass surgery. We can reconnect lymphatic and venous vessels, or we can transplant new lymphatic tissue, either lymphatic vessels or lymphatic nodes. And this means that we can achieve even more than traditional therapy, conservative therapy could usually do. And I don't want to say that it doesn't work. Done correctly, it works quite good, but this is a therapy for life. It's not reversible. It cannot reverse the flow of the evolution of the disease. And at best, it will offer some temporary regression, and that's it. So these are some examples of patients that were treated back in Timisoara with conservative therapy. In terms of surgical solutions, well, in the very beginning, surgeons were excising everything and skin grafting on top, and this was a hugely debilitating surgery and potentially also life-threatening due to the massive exposure of tissue and the risk of infection. And fortunately, we gave that procedure and then the similar procedures, we gave them almost completely up. What you're seeing in here is a brachioplasty, basically. This is still useful in particular cases where you have a lot of excess tissue after you remove the fluid content. There's some very exotic procedures where you can actually transplant a lymphatic vessel entirely, but with some debatable results. There's vein interpositions have been tried out also with some debatable results. What we know works best are two things. We know that lymph node transplant, they work, and this has been confirmed with multiple clinical trials all over the world. And we know that lymphovenous bypass works. And this because the majority of our colleagues around the world, they perform this kind of surgery nowadays in lymphedema patients. And this is the go-to choice for lymphedema if you can do it. And the future development is that more and more women which get breast cancer or any kind of cancer resection, which requires that you have your lymph nodes either in the axilla or in the groin completely explanted. This is an immediate indication for immediate reconstruction of those lymph vessels, which now no longer have any drainage anywhere. So those patients are at high risk of developing lymphedema. And I think there's not enough people in this world which can do this kind of procedure compared to the high number of patients which require this kind of procedure. So if you want to have job security, start doing this, because in the coming future, there's going to be more and more demand from patient side to have this. So what do patients ultimately want? Well, they actually want to get rid of compressions. They want to get rid of all the therapy that they have, manual drainage and so on. When you think about it, having massages 3 times a week sounds really interesting, sounds almost very luxurious, but in reality, after a while, it's just another burden in your life. And especially since you don't have it, then your leg or arm swells immediately up. So basically, this is what surgery is here for. This is together with some colleagues from my team in one of our OR. And unfortunately, we don't have palm trees, so we have to simulate a very nice view out of our OR. But at least it will bring memories back of Indonesia. So let's talk about supramicrosurgery and supermicrosurgery. But first, does anybody know who this guy is? Yeah, he's a Nobel Prize winner of medicine in 1912 for basically inventing vascular surgery. Before that, before Alexis Carrel, everybody thought it's impossible to resuture a vessel, an artery or a vein. Once it was cut, it was considered damage beyond repair. So it was Carrel which proved that you can actually resuture it and it heals and it works. And he did all these experiments on dogs. And if you look at this picture on the left of the screen, this looks absolutely identical to what we do even now in microsurgery, day by day. We just use smaller instruments, smaller vessels, and smaller sutures. That's it. But everything else is the same. And this is more than 100 years ago. That's why I keep saying it's about time that we get an upgrade to microsurgery. So what could the upgrade be? Well, we're using super small vessels. and super small sutures, and then very, very fine instruments. These are some of the most delicate instruments that we have today in the surgical field. These are made by a company in Japan called EMI, and they cost a fortune, obviously. And you need them in order to be controlling those super small vessels. And this is a 25 times magnification of a lymphatic vessel, and you can actually still see the vessel, the nutritional supply to the vessel itself. So why do we need to have robotics in all this thing? Well, this is a 1 millimeter vessel. You can tell, actually it's more than a millimeter. You can tell by the markings, by the lines on the approximator. So this is more than a millimeter, and this is a colleague of ours trying to record an educational video. And I'm saying trying because the tremor is quite intense. And this means that even at this big size, 1 millimeter or more, this physiological tremor that we have every day is our biggest enemy. This guy on the right, this is basically Dr. Harry Bunke, and Eklund, my God. This is Dr. Eklund, and he was one of the very early pioneers which identified that if you have the correct position of your hands, then you can control very nicely this fine tremor. And this means that now we reached a point where we need to decide what's coming next. So more than 100 years ago, we invented this procedure. Around the 60s, microsurgery with smaller vessels came up, O'Brien and Eklund and so on. Then we had the coupler in the 90s, and this replaced venous suture. And now the quest, the golden quest, is to replace microsurgery entirely. And I think robotics is the way to go. So if you go to London, there's a very nice museum of medicine. I saw you have one here as well. And if you go to London, there's a very nice museum, and it still has the surgical kit of one of the first surgeons or very renowned surgeons which did great amputations. And it's still sharp, listen. And it's still sharp, and you can still use it. But no one of us would use that kit nowadays, right? This is our set from modern times. But I do believe that in 20 years from now, probably no one of us will look back to this set and say, oh, can I have the old set for this? Hopefully in 20 years from now, we will use this microsurgical ability of ours in completely different ways. Liston was amputating feet and legs with no anesthesia. We do now free tissue transfer, facial transplantation, bilateral hand transplants, and so on. But I think what's coming is tissue generation. And for tissue generation, the solution is on an entirely different level. And I think this is the appanage of robotic surgery. And robotic microsurgery, this has been a pipe dream since probably 50 years now. And a lot of people have tried it, and a lot of companies have tried it. Because what we're actually doing now in microsurgery is kind of ridiculous. Every other field of surgery has dedicated tools for the job, except us. We still use our own hands with some fine instruments, and that's it. But in reality, what we need is a machine that does the job for us, and we control the machine. Or maybe we can create a machine that controls itself. So, bless you. This is a slide from a presentation on in my department in 2004. so 20 years ago. And this was robotic microsurgery was on the list of future plans. Well, 20 years later, we're here. And, this is the Da Vinci. Everybody knows it. I think everybody uses it right now in every hospital, every big hospital in the world. And Da Vinci can, in theory, and has been in theory, been used before for microsurgery as well. But it's too bulky. It's much more difficult. And this is what it looks like. This is me controlling the Da Vinci in ERCAD in France. These are some teppanyaki noodles. And basically you use them as a simulation for doing an anastomosis. The newest addition has been clip-on sort of robot which you attach to the surgical microscope, created in the Netherlands, in Eindhoven. And this has not been able to break through as good as the other machine, which is coming from Italy. Originally, now it's a US-based company, and this is called MMI, the company, and the machine itself is called Simani. And the name is basically from synthetic or artificial, the Sai, and Mani, which in Italian means hands, so artificial hands. And what can it do? Well, with it, you can anastomose very small vessels because you're able to very finely control and you're able to filter down and adjust the natural tremor that your hands have. It cannot do the suture for you or instead of you. It cannot do better than what you already can do. And if I put somebody else in my place, which has no microsurgical experience or little microsurgical experience, it will do, it will not create a good anastomosis. So here's a few things that over time I myself have been confronted with, and I heard every time from colleagues of mine as well. It's not a real robot. Why do you call it this way? Yes, the correct term is it's a telemanipulator. But then again, everybody knows what a robot is, right? And I don't mean this one. We call the Da Vinci a robot, even though it's still just a telemanipulator, as the surgeon sits in the console. We call Tesla a self-driving car, although it's actually not self-driving. And it's just incrementally adjusting for very, very small amounts of time. The point here is that we will start to hopefully change the pilot in the seat of the jet to just some automated, hopefully not malicious surgeon. And then times like these will be gone. This is a former colleague of mine. I'll go really quickly through the rest of these things. People complain it cannot do anything by itself. Yes, unfortunately, it cannot do that. So whenever we say robotic medicine, robotic surgery, this is what we think of. Some AI which does everything magically by itself. There is no such thing. And there will never be. Even despite all the rise in ChatGPT and all these things and OpenAI, those are not smart by themselves. At best, what we can do is we can create tools which will help us to better diagnose, better identify the things that we already do and the things that we're already good at. In France and ERCAD, they have combined these two, or they're working to combine these two things together. You can scan, you can completely digitize a patient, and then you can feed this information into a computer, which is connected to a Da Vinci robot. And then the robot can directly go to its target anatomic site and can start doing whatever it's being programmed to do. But we're still far away from that. And the biggest hope is coming from a partnership, which is between Google and Johnson & Johnson, which is basically the company which owns Intuit Da Vinci robots. And the official reason is to create self-manned, automated robots for Mars missions. But I think we're still far away from that. A lot of people like it, but then they say, okay, how much does it cost? Let me tell you the story of the first human genome. The first human genome costed more than 100 million US dollars just to sequence the whole thing, not to say anything about the research that went into it. That's impossible to quantify. Currently, so a few years ago, this was the price that I was advertised on Facebook for a full genome sequencing. And just like a month ago or so, I bought for a friend a kit, which was $99 for your entire genome. That's crazy, you know? That's from 100 million to $99. And the projection is that it will cost less and less as the technology scales up. The same thing will happen with anything robotic related. As we progress, as there are more of them, and as everything gets better. It requires a lot of special training. Unfortunately, everything new requires a lot of special training, and this is what it looks like. You hold in your hands some controllers which mimic the normal instruments in your hand, and then the tips of the Simani robot, it mimics your movements, or it simulates your movements. And those movements are scaled down by a factor between 7 and 20 times. This means if my hands move 20 centimeters, the tip of the robot moves only 1 centimeter. So this allows me for really great precision. And then you have to train quite a lot for it. The total training time, I would say, is depending on the surgeon and the number of hours that you put in. But I do say that it's quite a steep learning curve. And if you're not good at microsurgery in the first place to begin with, then it's going to be even more difficult. Unfortunately, you're going to end up more sutures than you usually are. And if you're buying 12 zero sutures, which one suture costs around $60, $70, $80 per piece, then this is going to be a very costly surgery. The suture can break very easily if you're not careful, if your assistant catches the suture, if you pull on it, if it gets caught into something. So there's many perils in this. You can very easily damage the needle. You can bend it because the robotic arms are very powerful. And unfortunately, you cannot dissect with it, not yet. So up till now, you can only do the actual anastomosis part. So this part where you put the two vessel edges together by using sutures and knots. And as you can see, this is highly zoomed in. And this is kind of almost in slow motion because as you are moving with your hands, everything is scaled down. And either you move very fast and then the robot moves kind of normal, or it's going to look like in slow motion. OR setup gets complicated when you have all these bits and pieces that you need to install in the correct order, sterility. Your nurses will probably hate it because it's extra work for them. And this is never welcome. And nevertheless, the last reason that I've ever heard is, I don't need this. I'm good with my own hands. Sure, but for how long will you still be good? up to which level are you still good? So there's always a limit for all of us, and I have probably 20 plus years of experience in doing microsurgery. And it's still something which I recognize that this has a particular indication. This was pictures from our first official case. This was the lymphovenous bypass of upper arm. And this is me at the console together with the best assistant I ever had. This is Professor Hamdi, the chief of the department in Brussels. And we had a very nice time creating 4 different anastomoses. And what you're looking at is a side to end anastomosis of a 0.4 millimeter vessel. And I dare anybody do that by himself, just like that. It's quite a challenge also for the really experienced microsurgeons. And this is what the setup looks like. Basically, we use optical microscope. The real benefit comes when you use it with an exoscope. For various reasons, we don't have it at the time being, probably in the future. So I'm using it with this current setup, which is a dedicated supramicrosurgery microscope, a Mitaka MM51. And this is what it looks like. Whenever I move my hands, the tips of the robot mimic what I'm doing. And this is what it looks like from the outside when I'm actually doing stuff. When I look at the movies, it looks kind of silly, but it is what it is. And through the microscope, this is what it looks like. To the left panel, this is by hand by the chief of the department. On the right side, this is by robot by me. It's not slowed down. It's not speed up. It's real time, both of them. The robot is a little bit slower than by hand, but not by much. And this was the first case that we recorded ever. After this, it gradually became faster and faster with the robot. And there are numerous problems that you can encounter. You can break the thread. It can get attached. This has a cutting blade as well. So you have a double scissors and needle holder. So there's a lot of technical things that I can spend a lot of time talking about. But the point is, with it, you can do very nice anastomoses, which otherwise with the hand would be at the very limit of what you can do. This is quite a big lymphatic vessel, and I chose this one because I wanted to be able to show what's going on. So you can nicely see the lumen in here and how we can control. But whenever any surgeon in the world, whenever he or she is doing this by hand, you will never have this steady hand that you have in this position. There will always be a little bit of tremor, including in myself. So this is what you can create with things like this. You can create an anastomosis of a vessel which is less, it's about 0.8 millimeter when you measure the lumen of the vessel. And as you can see in here, there is a little bit of venous reflux, but then in a second or two, there will be quite a lot of washout from the lymphatic system. And this is only able to be achieved with the help of very correctly placed sutures. There's no lymph leakage. There is no otherwise problematic area. And here you can see this is the natural contraction of the lymphatic vessel. So we know it's working, and the blood from the vein has been completely washed out. And here you can see the lymphatic contracting, and then it completely washes out all the um, all the blood in the vein. And then if we wait a little bit more, you see all the other modes, but that's not it. So you can have a lot of issues with it. It's still not the perfect tool, but we're working on it. And these are some cases. These are not done with the robot. This is cases where we have follow-up of 1 year, but they are representative of everything that we do identically. The only thing different being the robot anastomosis. So what I do is I do very targeted lymphatic anastomosis based on the dermal backflow pattern of these patients, and now starting to add the echographic diagnosis. And as you can see, there's quite a big volume reduction after 1 year post-op. Here you see almost 9.2% interlimb reduction. So what does interlimb mean? You take the volume of one limb, compare it to the other limb, and then you compare the difference of these two differences. And this is the most accurate indicator that you can have of progression either towards improvement or, getting worse. And these are all patients where we did exactly the same thing over and over again, and they have a really, really good improvement. This is the protocol that I use all the time. And I keep saying that it doesn't make sense to do any kind of this bypass surgery in patients which are not already for at least 3 months under compression, under manual lymphatic drainage and compression therapy. And what happens is then they get their OR. They get their OR, and for like this. And in the OR, we try to do a minimum of 3 LVAs. We start distal, we work up towards proximal, and as we progress, we also start to bandage the limb. And there's an entire story why this is needed. For 18 hours, they stay bandaged with very highly compressive bandages, and then they switch to flatten it for 7 days. They use it day and night for 3 months. And then after 6 months, they start reducing also the daytime usage. And the goal is to arrive at 1 year with no compression and hopefully with also no edema. And we've been looking back a little bit at our experience in Brussels. And what we saw is that when we compared patients which had LVA with patients which had just decongestive therapy actually creates an increase of volume. Even if it's a slight one, it's always, or most of the times, it's there. Whereas LVA managed to inverse the effect, and it managed to reduce this trend. What we saw is basically that in all these cases, be it with LVA or lymph node transplant or the combination of them, it's much better compared to not doing anything at all. And unfortunately, I wish that all of lymphatic surgery would be now summarized, but this was only the tip of the iceberg. And as one of my mentors used to say all the time, microsurgeons never give up. So if you enjoy this topic, this might be your start into this field of growing potential. And I think we're all plastic surgeons. And I think what we do best as plastic surgeons is to innovate. And you always have to find a way to do it better than all your other colleagues. I do thank you for your time. And if you have any questions, let's have some discussions.
I would like to invite Prof. Alex to sit down for Q&A sessions and discussions. So we're so lucky to have Professor Alex Nistor here. I was like looking at TED Talk, and it's truly an impressive and great presentation, Alex.
Thank you.
Congratulations. Your experience is very nice in this robotic lymphatic. So this is the chance for us to ask directly to the expert or visiting professors what you just presented, or if you have any other questions that you want to ask. I myself have already some questions for you. But so if you have any question, please just raise your hand and we'll distribute the mics. Uh, Maybe start with my question, Alex. I heard we're talking about the autonomic robots in the future, right?
Yep.
But you say it will never happen and stuff. I heard that these Simani robots actually collects data from surgeons that they put into their computers for future usage. That's actually moving toward the autonomic robot system. Is that true?
I would dare to say that probably this is a objective of theirs, but from an objective to actually being able to do that, it's a very long way. And for example, one problem is always the discussion: how long does it take to make an anastomosis using the robot? I think that's a wrong question, because if you see the exact movie recorded through the microscope of the entire anastomosis with the robot, there's always dead times. There's always something happening. Something that the tissue is dried out. The system has to rinse it. Your vessels are gone to a different position. You have to reposition. Your needle breaks. Something is caught in your instruments. There's a lot of things. There's a lot of garbage movements, I would say, which have nothing to do with the actual surgical time. And yeah, of course, it would be amazing to have this one day. This is the goal, I hope, to have this one day just ready at the press of a button, and then just like we do with the vein coupler, you just position the ends of the anastomosis in there. You push the button, and the robot does the thing by itself. But I think this might not be needed in the future. I think.
Right.
I think
Interesting.
in 20 years time, we're not going to be doing even this.
All right. Just my curiosity. Do the robotic manufacturer, when they say the robot, sign a consent that they will record everything, your movement, your
I'm
data
not
and stuff?
aware of that.
You're not aware of that.
No.
So maybe it's a gossip. So maybe any questions from the audience? I welcome you all to ask Professor Alex Stores. I recently saw your presentation that you're doing the side-to-end anastomosis. Can you say, I know it's very hard for me myself to do it. Can you say it makes you easier to do the side-to-end more often than end-to-end? What do you think?
I think it's a matter of finding the suitable indication and not pushing the indication to the patient just because you have a nice tool for it. So if the situation requires for you to do a side-to-end anastomosis, which and this most of my colleagues around the world, they agree, they are not as they produce less good results than the direct end-to-end anastomosis. But if the situation asks for a side-to-end, then this will make it a little bit easier, because especially the back wall segment of very small vessels, and then you have to have a little bit of tension as well, especially for side-to-end. And that setup has been made quite easier with the help of the robot.
Exactly right. So if you try to conclude uh, the most important benefit of using robots in your own words.
I think it's a way forward.
All right.
So it has to start somewhere. And intentionally, I put that slide with the first appendicectomy, laparoscopic appendicectomy. Also, at that time, that guy was a gynecologist,
All right.
and he was almost assaulted by the general surgeons. How dare you? How
Because he's
dare you do
gynecologist.
something like that or say something like that?
All right.
And they were very, very skeptical of his technique and ideas and whatnot. Well, it turned out he was right. So it has to start somewhere. Unless more and more centers around the world start to push this and gain momentum, and there's more cases, there's more trials, we figure out what works good, what works not so good. We change it as we go. It will never happen. The company is not responsible to do our own better judgment. The company is not substituting your critical thinking as a doctor. So it offers you a tool. And then it's up to you what you do with that tool. If you say, I don't want this tool because I'm a super microsurgeon and I can do it with my left hand while sleeping, okay, no problem. But then you will be left behind in 20 years' time, just like those general surgeons were when laparoscopy became the standard.
Yeah, pretty makes sense. So, all right, let's have some question from audience, or should I? All right, Adi Basuki, Alita, please. These are our residents.
Thank you very much, Prof, for your time and great presentations, of course. My name is Adi Basuki. I'm one of the plastic surgery residents. I'd like to ask about, you just said that our ability as a surgeon is limited and robotic surgery help to increase our performance. Can you please elaborate more about it? And because I've never seen any of the anastomosis with the robotic before. And then the second question is, how long have you been doing the lymphatic anastomosis with this kind of robot? And do you have any data regarding the success rate about the robotic usage? Thank you.
All right.
Okay, so that's quite a lot of questions. I'll try to answer them in the order. So in terms of improvement, um, again, I repeat what I said a little bit earlier. If you are good at microsurgery, this will make you even better. If you are not good at microsurgery, this will not make you suddenly, magically very good. That's the bottom line. If you are a good microsurgeon, you will be able to do more, better, and at smaller levels. But if you're not so good microsurgeon, I think you risk some failures. Regarding the time that we had the microscope, we got it at the beginning of April this year. So we have it we've been using it for some 3-4 months, because now during summer, July, August, it's mostly holidays. So in these 3 to 4 months, we had some 21 cases in total. And I hope that this trend will continue. We are fully scheduled for the entire year, so we know exactly what's coming. And in terms of the success rate, this has always been 100%. For the simple reason that if I'm not satisfied with the anastomosis, I will not just close the skin and that's it and pray, but I will redo it. And I will redo it as many times as it takes until it's done right. And that's it. So from this point of view, that the question I think that you're asking should be different. Those colleagues of ours which report a failure in lymphovenous anastomosis, I think they managed to pick a wrong site. They managed to pick a place where they shouldn't be at all. And this is why it leads to a failure. So the planning was actually the failure, not the technical surgical part. So if you plan very well, if you correctly choose the vessels, if you see exactly both uh, with magnetic resonance, with ICG, with Doppler sonography, with whichever imaging technique you prefer, when you see that the vessels are in the correct configuration that you need, then that's your recipe for success. Yeah.
All right. Any more questions, Adi Basuki?
Please.
Sure. Why not?
So actually, I'm also curious about you said that you will redo the anastomosis if you're not satisfied, and then with robotic surgery, how many times do you redo it? Is it different if you do it by hand or freely?
Again, this redoing an anastomosis is very rare, very rare. By hand, it's very rare. It happens most of the times when, for a reason or another, there is a lot of venous reflux. And then what I usually do is I take interpositional vein graft with some valve and I insert artificially a valve in there to block the reflux. So that's the redo part. But for the robots, I think in all of these patients that we had so far, I've done it maybe once. Like I completely cut it out and redid it for whatever reason. And this is all reported in, we're part of a clinical trial now.
All right. I think we should move to the next questions. Yep.
Thank you, Professor. My name is Alita. I'm a PGY4 resident here in RHM. I would like to ask, firstly, in the age of artificial intelligence and the development in medicine, do you think that we should, and how do you think we should approach in terms of data protection and uh, its risk of having interference from either the company or any other individuals that may interfere with the systems and the robotics that we are using instead of our own judgment. And the second question would be, as upcoming surgeons ourselves, can you please elaborate your process of introducing this new tool and new process that you introduce to your centers, so that we may know what is your extensive process and steps of having this whole new system in your center. Thank you.
Okay. So if I may summarize, data protection, right? I don't know. I'm a surgeon. So I'm the guy which they send to do the surgery. I think data protection should, as doctors, should not be our concern. We have entire IT departments for that. We have lawyers for contracts. We have legal advice. We have all these things, and we should not consume our time and our worries with things which are beyond our reach. Besides this general advice, I would say that I think this is a little bit over exaggerated. Everything that we do nowadays is logged and traced and tracked and whatnot. So unless you want to live on an island in the middle of nowhere, that would be the other option. You have to accept it. This comes at a package with modern medicine, modern civilization. Take it or leave it. So I don't think there's a way out of this. as for the second question, what was the process? We have been involved in the development of this machine for a long time. Professor Hamdi for probably more than 5-6 years now. I first saw a prototype of this machine probably in 2014. So that's almost 10 years ago. And the machine was already in work for probably 5-6 years before that. So it's quite a long developing process. So we were quite familiar with what it does and what it represents. And I think the selling point for us has been that it will enable us to be part of this, let's say, elite of departments around the world where you can actually have this and use it for research and use it for improving this whole department, this whole domain, and to create more knowledge. And I don't think this you will ever be able to sell as a tool which will help your hospital or your department to save time, to save money, no, it's the exact opposite. It will cost you time, it will cost you money, it will get you back research, and it will get you back prestige. And that's it. For the moment. In the future, probably this will change. It will probably in the future save you money and save you time.
And that's also preside us to the burning questions. How is the cost of this machine?
I think
And
you have to
what's the
ask your
cost?
local representative for that. I'm not a
Give me
company
number.
sales person. I don't know.
You don't know, right?
No,
Even
because
cost,
this is tailored to just like what loops do you wear, Ryan?
Synosis?
Xenosis.
Yep.
How much were your loops?
20 millions. It's around 2,000,
Okay. If you go to the United States, you can get them for a different price.
700, yeah.
You can get them for a much bigger price in Belgium. And probably if you go anywhere else in the world, like, I don't know, in China or wherever they have import fees, you get them for triple that.
Got
So
it.
I don't think the price is what matters. The price is variable based on what business they do. I think what you need to, again, we're not businessmen, we're not economists, we're surgeons. You have to talk to your hospital and convince your hospital that this is something that will benefit you in the long run and that this will bring to the hospital a value added image quality which they cannot get for anything else.
All right. Yep. Well, another questions? Over there.
Good morning, Professor Lister. My name is Erin, and I am from my third year of plastic surgery residency. I'd like to ask you regarding the lymphatic liposuction. What technique do you use to do it? And is it possible for you to do it by your robotic technique? Thank you.
Yes. So lymphatic liposuction is no different than a regular liposuction, except it's much, much more aggressive. So in aesthetic liposuction, you probably go around 1-2 liters at most. In lymphatic liposuction, it's not uncommon. So it's quite common to have around 7-8 liters per session, which is a lot. So the only thing that differs is how you plan for that big volume loss. And unfortunately, the robot is of no help there because we're dealing with just a regular macro environment and there is absolutely no usage for the fine precision movements which the robot enables.
I hope that answered your question. Maybe you can give the mic to, yep, Vida, please. Plastic surgeon.
Good morning, Prof. Mister. My name is Vida. I'm already finished my board examination. I would like thank you for your awesome lecture. I'm curious about the duration of the robotic surgery. Is it shorter because you mentioned the dissection was done manually? And if it's shorter, does this mean the procedure can be done office-based with local anesthesia?
So you mean if the procedure is shorter by hand?
By robotic,
By
the
robotic.
duration, yeah.
No, the duration is always longer than the hand because you have to add the additional time to set up the whole system, to drape it, to install it. You have to change your position multiple times. We do it in general anesthesia, but this is mostly for the patient's comfort, not for anything else, because we deal with mostly middle-aged or old elderly patients, and back pain is their number one complaint. When they sit even awake for 1-2 hours on the table, and then they prefer to be asleep. This is the only reason. But this can be done with or without the robot in a complete office-based setup if you have a very good planning. If you don't have a precise planning and if you don't have the exact site under your cut on the skin, it will just be a failure. So you have not the luxury of looking around in the incision site in an office-based environment. But it can be done, yes.
Thank you, Professor.
All right. Maybe, yes. Okay. Special question from our faculty, Dr. Devi. He is also one of Takumi's fellow.
Thank you, Professor Alex. Thank you for sharing your experience with us. My question is related with clinical application. And after you perform LVA, based your experience, how long you ask the patient to use compression garment?
So for compression garment, it's immediately after. It's actually during surgery, and they stay on with it until the new compression stocking arrives, which is usually 7 days. So they stay either bandaged or with a very good fitting compression stocking that they had before. And then they keep the new one for the first 2 to 3 months, day and night. And after 2 or 3 months, whenever we have the next visit, we decide most of the times to remove during the night, because this means the progression was good. There's a good reduction in volume. There's no relapse. And we remove the nighttime wearing. And then after 6 months, we usually start to decrease the amount of time that they use daytime compression until we find the threshold where they need it.
Okay, thank you. And after you, and when you decide to perform lymph node transfer after, let's say, if your LVA not successful,
When you don't have a good result at 1 year post-op after LVA. So if you do objective measurements, meaning volumetry, perimetry, MRI scans, and then you have an objective comparison at 1 year post-op, and you see that it actually got worse, and you see no other options for further LVAs, then probably this is a candidate for lymph node transplant. With the addition that you have to wait another year until you can see if it's actually working or not.
thank you.
All right. Thank you, Dr. Devi. I think we can have 2 more questions. People in the back. I can see. Amira, yeah, please. And then next, Gama.
Thank you, Professor, for the amazing lecture. My name is Amira from Plastic Surgery Resident. I want to ask about the criteria for robotic surgery. Is this surgery applied for all patients, or there are specific criteria such as age, severity, or this is for the first operation and or specific technique for the robotic surgery and for lymphatic surgery too? And maybe there is any screening before. And the second question is operation covered by insurance in your country? Thank you, Professor.
Okay, I think I will need a little bit of help with the first question. If I understood it correctly, you're asking of the office-based procedures?
The robotic.
The-
She's asking about the robotic. What's the indication? Sex, age.
There's no different indication for the robotic besides the actual indication for lymphovenous anastomosis.
All right.
If there is an indication for LVA, you can do it in any patient with the robot, unless there's one exception. They have a pacemaker. So if they have a pacemaker, it's not indicated because of the magnetic field that you have to detect the movements.
And the second question is about insurance.
Insurance. Basically, if you have a very nice surgical instrument in your hand, or you have a very crappy one, the surgery goes the same, right? And for the patient, the outcome is the same. And for the insurance, they don't care what kind of instrument you use in your hand. So this telemanipulator, this so-called robot, is just another tool. Insurance will not take part into increase of bills. So they will not accept that you pay, that you ask, or the hospital asks for more money. That's clear from the start. So there's two options. Either the patient is agreeing to share the increase of costs and pay by himself, or you find by means of research grants, of foundations, of sponsorships, a way to finance this until this will become the standard, just like Da Vinci is now for prostatectomy. In urology, all the insurances in the world, they fund the robotic surgery because there's less complications. And in the long run, it's cheaper.
Yeah, it's nice knowledge for us about the insurance.
Yeah.
So they don't cover the extra cost.
Yeah.
All right. Next question. I think this is the last one. Please distribute the mic.
Thank you very much for the opportunity. Thank you for your great lecture, Professor Nestor. I have one question for you. You're saying that you're using a different, you're using the Simani robotic instrument. So are you using this robotic instrument for the whole procedure or just the anastomosis? Because since you're also showing us a robotic DF in your presentation, I assume that you're using the robotic technique for like DF reconstruction with immediate vascularized lymph node reconstruction as well. And since we know that this this robotic instrument is smaller than the Da Vinci, and how do you how do you use it with simultaneous reconstruction? Thank you very much.
All right. So yes, it can be used for any kind of surgery where you have the need to perform an anastomosis. So you can use it for any kind of free flap. In fact, the majority of the centers that have the robot, the Simani in Europe, I think now there's about 10 or 12 centers in Europe which use it. The majority of them, they use it for free flaps. And very few of them use it consistently day by day or week by week for lymphatic supramicrosurgery. So it can be used very good, with very good success in flap surgery as well. Another really good indication is nerve surgery, but it has to be superficial nerve surgery at the moment, you're not allowed to go into orifices, cavities with it. For example, you cannot do ENT surgery with it. That's beyond the manufacturer's intent of use. This is not to say that if you decide on your own risk and liability that you want to apply it, they cannot stop you, but I wouldn't recommend it either until they actually clear this. And I'm using it for lymphedema, probably out of all the patients that we did, 95% were lymphatics with the robots. Why? Because free flaps we can do really good with our own hands as well. It's not to say that sometimes it wouldn't be of help to have the robot, but it's not only me. There's also colleagues of mine and so on. So I personally, for the lymphedema surgery, I find that this is really helpful. For the free flaps, I think we have to see the results. We have in the whole of Europe, we have a multi-center clinical trial going on, which is probably due to be scheduled to come to an end sometimes at the end of next year. And when the results of that study will be out, then we have a clear overview by how much or how little this will help with regular free flaps. So I cannot give you a number, but I do think that it helps to create a little bit more security in the anastomose that you do. So I expect that the revisions with the robot will be less than the revisions by hand.
Thank you, Professor. All right, considering the time, I think we have to close our Q&A. Oh, Dr. Henny, our program director, please.
Thank you, Professor. One last question for me. I'm very happy that my residents are eager to listen to your lecture, and it is a very interesting lecture. I understand that you're coming from a university hospital, so you must have many residents as well there. So currently, this robotic surgery is still a learning process for the faculties right now. But I would like to ask you in the future, how would this change the way you train your residents? Like in the beginning, you said that if you're not a good microsurgeon, then you're not gonna do better in the robotic surgery. But maybe after you're good in robotic surgery, the faculties, maybe it will change your mind. Maybe you will start to teach your resident by directly using the robotic surgery. Like maybe from now on, they should prepare their Nintendo skill from now. So they're good at with their hands. So will it change in your opinion? Thank you.
All right. Thank you for the question. I think that the training of the residents with us, we're a small department by number. So it's not dozens of residents, and they get a very thorough training. They are exposed throughout their entire time of residency to a lot of surgeries, and they're being trained quite good. And they are encouraged to start training themselves with the robot. As a matter of fact, now, as I'm on holiday, basically, the machine is sitting idle, and one of the things they have to do is log in their training time with it. So there's certain steps they have to perform, and by the time I'm back, they have to show me what they've done. So that's one of them. We encourage them to use it. We encourage them to use as much of their free time to do regular microsurgical training. We have a small training room which is set up just for this with three microscopes actually, and they can use it at any time of the day. I think that it's up to the person himself or herself to decide how much time they want to invest in this. And there's no cutting corners. If you don't spend time with it under the microscope with the robot itself, then it's not going to work. So coming to your second part of the question, I don't think you can improve this by playing video games. As good as this might sound, what you really have to improve is to get good or get better at microsurgery, regular microsurgery.
All right. All right. Well, I think we have a really great discussion, but it has to be continued for the other schedule. So,
And
yeah,
obviously, if there's any more questions, please feel free to write me or text me, and with pleasure, we can continue the discussion.
yep. Thank you, Prof. Alex. And I think we have to, yeah, please applause.
Thank you so much. You're too kind.
For the last part, I think we will invite Dr. Parintosa as the head of reconstructive microsurgery section to give a closing remarks and some small souvenirs for our visiting professors. Please, Dr. Parintosa, go to podium.
Thank you, Prof. Alex, for coming to our hospital, our Faculty of Medicine, especially in the training program. We are very happy to have you as a speaker. It's very, very interesting and marvelous tools for us that our resident know about the microsurgery about also just the microscope, and so the small tools is very, very interesting. And also, I hope our resident and also from Dr. Henny will continue for the next scientific program or the research with you. Thank you very much.
All right, so it's time for souvenirs and photos. Can you please start? And Dr. Parintosa will give you souvenirs. Can you please take pictures? Can you show that?
Sure. I don't know myself. Oh, okay.
Russell have
It's a lot
200
of
days.
brain.
Yeah, 200 days.
Absolutely.
All right. Can you also please hand the certificate, Dr. Ochan, to Alex? Please, I would like to welcome Dr. Haney from the Plastic Surgery Program Director to give the certificate of visiting professor to Dr. Prof. Alex. Photo, please. Last time, I would like to invite all faculties to go in front for photo with Professor Alex.